Good morning, good afternoon, good evening. Hope everyone is doing well. My name is Adam Morales, and today I will be presenting our proposed healthcare system for Nepal. It is developed by Frederick Shaw, Kathy Amok, and myself. Our main goal was to create a healthcare system that's sustainable, practical, and designed around Nepal's specific healthcare challenges. Instead of copying one healthcare system exactly, we built a hybrid model by taking proven parts from a successful system around the world and adapting them to Nepal. To start off, this is the slide on system structure. The public sector would serve as a foundation of healthcare delivery, especially for primary care, prevention, and emergency medical services. The World Health Organization has repeatedly emphasized that strong primary care systems create better long-term outcomes and improved access, especially in some of the lower resource settings. We also believe that providers working in rural areas should receive stronger incentives. One of Nepal's biggest issues is uneven provider distribution, where most doctors stay concentrated in urban areas. The private sector would still exist, but mainly for advanced and optional treatments. This helps reduce pressure on the public system while still allowing higher level specialized care. At the central government level, the focus would be policy, regulation, and insurance oversight. At the local level, hospitals and clinics would have flexibility in how they deliver care while still being held accountable. One major goal is coverage based on travel time. In Nepal, geography is one of the biggest barriers to healthcare. Research on rural healthcare systems show that travel time has a direct impact on survival and treatment outcomes. That's like the main reason why our model aims for patients to be within about 30 minutes of primary care, within a few hours of a hospital, and within 8 hours of trauma care. To help make that idea more realistic, especially in mountainous areas, we use mobile clinics and telemedicine. Adopted elements from other systems. For this system, we studied several international healthcare models. From the UK's National Health Service, we adopted the beverage model for essential healthcare and emergency services. The NHS has shown that government-funded emergency care removes financial barriers during critical moments. From Germany, we adopted parts of the Bismarck model, specifically some payroll-based insurance. Germany consistently ranks among the strongest healthcare systems in Europe, and much of that stability comes from shared employer and employee insurance contributions. From Canada, we adopted the single payer concept of universal access. Canada's healthcare system is built around the principle that access should not depend on income. By combining all of these models together, we take the strongest parts of each system, which is the government-supported access, stable insurance funding, and universal coverage. Financing breakdown. Healthcare systems only work if they can be funded long term. According to the World Health Organization, countries that rely too heavily on out-of-pocket payments often see some of the highest rates of delayed treatment and financial hardship. That's the main reason why our model uses three major funding sources. The first one is government spending, which covers essential services like vaccines, maternal care, primary care, and EMS. These are considered some of the high value services because they improve public health and reduce long-term healthcare costs. The second source is payroll-based insurance contributions. This creates a stable financial pool while sharing responsibility between employers and workers. The third source is private out-of-pocket spending, but only for non-essential or elective procedures. The goal is to spread the cost across multiple systems so that no single source becomes too overwhelmed. Payment methods. How providers are paid directly affects how they practice medicine. For hospitals, we selected diagnosis-related groups, also known as DRGs. Research from European healthcare systems, especially in Germany, have shown that DRGs improve efficiency because hospitals are paid based on the patient's diagnosis rather than charging endlessly for individual services. For, for primary care, we selected capitation. Research in preventative healthcare shows capitation improves long-term management because providers are rewarded for keeping patients healthy rather than treating illness. For specialists, we kept fee for service. Specialty care often varies greatly depending on complexity, so flexibility matters in this situation. By combining these payment methods, we improve efficiency while maintaining provider motivation. Safety nets and coverage. One of the most important parts of any healthcare system is protecting vulnerable populations. Research from the World Health Organization on universal health coverage shows that low-income families, children, elderly populations, and rural communities are often the most affected, uh, most are often the most affected when healthcare access is weak. That's why these groups are specifically protected in our system. Coverage includes primary care, emergency services, and essential medications. We also include reduced cost programs for people who qualify. The goal here is health equity because equal treatment does not always equal outcomes. Pharmaceutical regulation. Because one of the biggest cost problems in healthcare is medication pricing. The World Health Organization's essential medications model has shown that governments can reduce healthcare costs by significantly regulating essential drug pricing. Our model uses price caps on essential medications. We also use reference pricing, which means comparing medication costs against successful international systems. Research on pharmaceutical regulations show that bulk purchasing lowers costs by increasing buying power. We also prioritize generic medications first. The World Health Organization research consistently shows that generic first systems improve affordability without reducing effectiveness. We also believe chain transparency is critical. Many healthcare systems lose money not from care itself, but from poor pharmaceutical oversight. Expected improvements to the system. With these changes, we expect improvements in three major areas. The first one is quality. World Health Organization research shows that stronger primary care systems improve long-term health outcomes. Second is access. Universal coverage, telemedicine, and mobile clinics help bring healthcare closer to underserved communities. Lastly is cost. Studies on drug pricing regulation and payment reform show that cost controls reduce unnecessary spending and improve long-term sustainability. Our goal here is simple: better care for more people at a lower cost. In conclusion, this healthcare system combines proven ideas from some of the strongest healthcare systems in the world and adapts them specifically for Nepal. It creates access through public care, stability through shared insurance contributions, protection through safety nets, and affordability through pharmaceutical regulation. Most importantly, it creates a healthcare system that is realistic, sustainable, and designed around the needs of Nepal's people. Thank you so much for tuning in. Hope you enjoyed our presentation. And here is our list of references. Have a good one.